Can you see?
Yes, doctor, we can
my
see
presentation?
We can see it, doctor.
Okay. Okay, so good morning, everybody. This morning, I'm going to talk on cancer-associated thrombosis, a fairly common problem. So what I'm going to do is consider in the introduction the epidemiology of disease and other important data related to cancer-associated thrombosis. I will also touch upon on the mechanisms of thrombosis in cancer. How does it develop? Then I will talk on the risk assessment. How do we risk assess a patient with cancer-associated thrombosis, and how do we make the diagnosis? And eventually, I will talk first on the treatment of cancer-associated thrombosis, and I will also touch upon on the prevention of the disease in cancer patients. Can everybody hear me? Is it clear?
Yes, doctor, it's clear.
Okay, so I have used references, as you can see, particularly the International Clinical Practice Guideline, which was published in 2019. Basically, this is a French guideline. The second is the ASCO guideline. The third being the most recent NCCN guideline. And then the American Society of Hematology forwarded the last guideline in, I think this was in February, last February. I have also used relevant references when necessary. So as an introduction, the relationship between cancer and thrombosis was first described more than 156 years ago by a French doctor. I think everybody have heard about him, Armand Trousseau. He described a syndrome of migratory thrombophlebitis, okay? And he considers this as a forerunner of an occult visceral malignancy. And as a result, subsequently, his name was coined the Trousseau syndrome. And by the way, Armand Trousseau himself developed gastric CA. He describes the syndrome on himself. And unfortunately to him, he died 2 years after he described the syndrome because of gastric CA. So subsequently in 1977, Sachs and colleagues extended the Trousseau syndrome to include chronic DIC, like you might have seen patients having peripheral dry gangrene and so on as a result of chronic DIC, varicose endocarditis, arterial emboli, and DVT, wherever it is, were included in the Trousseau syndrome. So as you can see here, this is a classical clinical manifestation of Trousseau syndrome, where you see painful, raised, erythematous palpable cords, okay, of migratory superficial thrombophlebitis. So if we see this kind of clinical manifestations, and if there is no straightforward explanation for this manifestation, you have to consider the possibility of an occult malignancy. So venous thromboembolism or cancer-associated thrombosis, a common cause of morbidity and mortality in patients with malignancy. And they have a 4 to 7-fold increased incidence of VTE when you compare this to the general population. Cancer-associated thrombosis accounts for about 20% of all VTE events that occur in the general population. And also, of all the patients who have malignancy, okay, in a certain period of time, 20% of them would develop cancer-associated thrombosis during the course of the disease. And when autopsies were done in these patients after days, then more than 50% of patients had cancer-associated thrombosis here and there. So ambulatory patients can also have deep venous thrombosis. So in the first year of after diagnosis, it is expected that 5 to 10% of them would have cancer-associated thrombosis. There have also been multiple reports indicating acute arterial thrombosis in the setting of malignancy. And in one recent study, in about 6 months, 4.7% of the patients had arterial thrombosis when compared to about 2.2% of control patients. So cancer-associated thrombosis remains the second most common cause of death in these patients after the disease itself. The prevalence, incidence of cancer-associated thrombosis has steadily increased, particularly during the past 2 decades, because of the increases in cancer prevalence, incidence, complications of its treatment, such as, for example, the administration of hormones, steroids, and other medications that actually predispose individuals to thrombosis, the use of central venous catheters, and also because of the long survival of cancer patients due to improvements of therapy. So as you can see, the risk associated with specific tumor types, the most common reported were the so-called mucin-producing malignancies, such as pancreatic CA, stomach CA, but brain CA, and interestingly, acute myeloid leukemia is also one of the common causes of cancer-associated thrombosis. The other hematological malignancies, such as lymphomas and other malignancies, actually have average less than 4% of them develop cancer-associated thrombosis. So in general, the risk of venous thromboembolism neoplasia is increased because of the activation and the imbalance of the cellular elements of blood. Platelets are activated, as we are going to see later, neutrophils and monocytes that produce tissue factor and therefore increasing the cancer-associated thrombosis development. Their function may also be abnormal. There is also increased generation of coagulation factors, okay, including tissue factor and other procoagulants that initiate thrombosis. There is also an imbalance, decreased levels of naturally occurring anticoagulants, including antithrombin, protein C and DS. And there is also the endothelium under normal circumstances, which is actually, thrombosis does not develop. But in these patients, because of the endothelial dysfunction, okay, the tendency to develop thrombosis increases, and at the same time, there is decreased fibrinolytic activity. Other contributing factors in malignancy include increased adhesive interactions between tumor cells and vascular endothelial cells, as I said earlier, because of P-selectin. This is a cell adhesive molecule that results in the formation of a nidus, okay, for clot formation. Tumors may penetrate the vessel wall, as you know, destroying the endothelium and promoting clot formation. External compression is also possible with, particularly solid malignancies and lymphomas. Neovascularization with many neoplasms also stimulates clot formation. So in the cancer-associated thrombosis, the virtual triad, as you know, also applies, and actually it is more so in patients with cancer-associated thrombosis. So in summary, what I said was this is the tumor cell. As you can see, the tumor cell on the left-hand side that produces procoagulants, including tissue factor and other factors that increase coagulation, resulting in direct blood clotting activation and thrombin and fibrin formation. And also it activates cellular elements of blood, and therefore they release different cytokines and result in activation of host cells that include endothelial cells, platelets, and leukocytes. And eventually, taken together, thrombosis develop. And the other very important aspect of thrombosis is the activation of the monocytes and neutrophils, as I said earlier on. The monocytes release tissue factor after activation, resulting in blood coagulation, increased blood coagulation. But the neutrophils, on the other hand, besides the production of tissue factor, they also form the so-called neutrophil extracellular traps that trap the platelets, they activate platelets and trap them, and therefore they coagulate, they come into close proximity into each other, okay? And they are activated, and therefore the tendency to develop thrombosis within the vessel increases, and eventually all these taken together will result in blood clotting activation and thrombus formation. So after seeing the pathogenetic mechanisms, how do we risk assess and diagnose cancer-associated thrombosis in these patients? So many of the risk factors for the development of VTE in the general population are also present in these patients. And the risk for VTE in cancer is determined by a number of coexisting risk factors, okay, that can be broadly classified into three. They could be intrinsic and extrinsic patient-related factors. They could be cancer-related factors, the malignancy itself. They could also be related to the treatment of the malignancy. But in general, you cannot really consider one risk factor or one factor from this category. All play a role in patients with malignancy and the development of cancer-associated thrombosis. So what I said in brief is, like, for example, if you start with the patient-related factors, the age of the patient, okay, maybe the detail is the patient-related factors include the age of the patient, the gender. For example, females are affected more in this category, immobility and other problems, okay, comorbidities, inherited thrombophilia, prior venous thrombosis are very important. These are patient-related. And cancer-related problems include the cancer type itself, as we say, like pancreatic, brain, as well as stomach, okay, which have very high association with thrombosis, metastatic disease, chemotherapy itself, as we are going to see later, like L-asparaginase, for example, in our case, hormone therapy, and other anti-angiogenic therapy like thalidomide, and other therapies would be complicated by thrombosis. And the other thing is treatment related. It could be surgery or radiotherapy, and hospitalization that would actually is a risk factor for the development of thrombosis in this group of patients. The treatment itself, as I said, and so on. And by the way, erythroid stimulating agents such as erythropoietin transfusions themselves may also increase the incidence of thrombosis in this group of patients. Very important factors that we should remember are the biomarkers in this situation in cancer. So if the platelet count is more than 350,000, the tendency to develop cancer-associated thrombosis increases. The white cell count, 11,000, elevated D-dimer, high levels of tissue factor, high levels of P-selectin, as I said earlier on. This is a cell adhesion molecule, and raised C-reactive protein are biomarkers of cancer-associated thrombosis. So if we, for example, take age in one study of 306 patients, 43 patients developed cancer-associated thrombosis, and 77% of them actually were above the age of 45 years. So age has a very important, is a very important risk factor in the development of cancer-associated thrombosis. Treatment. Different chemotherapeutic agents actually induce or are risk factors for cancer-associated thrombosis. So as you can see, for example, take L-asparaginase. It alters plasma levels of procoagulants such as antithrombin 3, protein C, and S, and therefore a tendency for thrombosis, which we have seen in some of our patients. Tamoxifen alters plasma levels of factors. It increases factor 8. Dexamethasone the same, and also, erythropoiesis stimulating agents such as erythropoietin also increase factor levels and also tissue factor, and therefore may be associated with cancer-associated thrombosis. The immunomodulators, thalidomide, lenalidomide, pomalidomide are very important, treatment modalities, particularly in multiple myeloma. But interestingly, these are actually associated or result in endothelial damage, altered plasma levels of, factors such as factor 8 and von Willebrand disease, and therefore are associated with increased incidence of thrombosis in this group of patients. That's why this patient should be put on prophylactic anticoagulation. Now then, during the risk assessment and diagnosis, we have to make an accurate and timely diagnosis of the disease. Therefore, if you make a diagnosis earlier on, you can save the life of the patient. Otherwise, it's a life-threatening complication of cancer. So the approach to the diagnosis of venous thromboembolism in non-cancer patients, as you know, involves a stepwise process, beginning with the assessment of pretest probability of VTE using validated clinical prediction rules, such as the Wells criteria. And then we do the D-dimer, and actually we confirm or refute the diagnosis of venous thromboembolism under, these are patients without cancer, okay? Therefore, this would be helpful actually to confirm or refute the diagnosis. If you consider the diagnosis of thrombosis, then this is followed by imaging studies. However, in cancer patients, studies have indicated that clinical prediction rules and D-dimer testing may not be as accurate or as useful in patients with cancer. Studies have shown false positive D-dimer assays that are increased threefold in cancer patients, so we cannot use this. It is therefore advised that in cancer patients with suspected cancer-associated thrombosis, one should proceed directly to imaging studies to confirm or exclude the diagnosis of cancer-associated thrombosis or thromboembolism. So when you work up a patient, this is a routine one. I should not go into details, okay? So after, making sure the baseline investigations are done, as I said, you have to immediately, if you have a clinical diagnosis, okay, high suspicion of a clinical diagnosis of cancer-associated thrombosis, then you have to do compression ultrasonography, which we call duplex ultrasonography. And if you suspect PE, pulmonary embolism, then CT, pulmonary angiography, should be done for the definitive diagnosis of the disease. In patients with high index of suspicion of DVT or PE without any known contraindications to anticoagulation, you should not wait until the result comes. They should be anticoagulated immediately unless there are contraindications. And then when the result comes, if the diagnosis is confirmed, you continue on treatment. If there is no really disease, then you stop treatment, put them on prophylaxis, and then follow the patients subsequently. Okay, after saying this, how do we treat cancer-associated thrombosis? Treatment proper. So the therapeutic landscape of VTE in cancer patients is challenging because of the increased risk for thrombosis recurrence. As you know, in malignancy causes thrombosis recurrence frequently, and the patient could also bleed. So you have to balance between these two events. So for more than a decade, low molecular weight heparin have been the gold standard for the treatment of cancer-associated thrombosis. As I would show you later, studies have shown that the low molecular weight heparins were better than the oral vitamin K antagonists such as warfarin. So the clinical trials have tested the efficacy and safety of low molecular weight heparins versus vitamin K antagonists for the treatment of VTE, and the low molecular weight heparins have showed actually efficacy and reduced risk of recurrence, and there was no actually increased risk of bleeding in the studies. Okay, so these are the baseline studies that were done in the end of 1990, 2000. So as you can see, the first study, they tried to look into recurrent VTE with low molecular weight heparin versus vitamin K when they compared them and look for measured bleeding as well as measured bleeding in the low molecular weight heparin patients and the warfarin patients. So if you see for example, the clot study, okay, recurrent VTE with low molecular weight was 8% as compared to 16% in patients given warfarin, okay? And the bleeding rate was 6 versus 4%. So actually in this study, the low molecular weight heparin actually resulted in increased bleeding, but it was not statistically significant. And so on and so forth. So these studies confirm that low molecular weight was superior to vitamin K antagonists such as warfarin in the treatment of patients with cancer-associated thrombosis. So based on the results of these studies, international guidelines have suggested the use of DOX, so based on these studies, guidelines have uniformly endorsed low molecular weight monotherapy as the standard of care treatment for VTE in cancer-associated thrombosis for 3 to 6 months based on indications. Now then, as you know, in the general population, the direct oral anticoagulants were found to be effective and easy to administer. So beyond their favorable efficacy and safety profile, low molecular heparins, they had low risk for major bleeding, particularly intracranial bleeding. These agents have the advantage of predictable effect, ease of administration, and no need for laboratory monitoring. So this is a new development. The DOCs were actually very important medications in the treatment of thrombosis in general. So recent randomized controlled trials have assessed the efficacy and safety of DOCs in comparison with low molecular weight heparin, dalteparin, or enoxaparin, where the low molecular weight heparins that were used in the comparison studies, okay? So based on the results of these studies, international guidelines have now suggested the use of DOCs for the treatment of cancer-associated VTE in selected patients, not in all patients, but in selected patients. So these are just the more recent studies, okay? 2020, the Caravaggio study, which actually had, in general, 2,000, almost 3,000 patients were involved in these studies. So as you can see, the Caravaggio had 1,000, more than 1,000 patients, and the Hoxai study also. So they were done, the APIC7, rivaroxaban, edoxaban, and the ADAM VT study also used APIC7. They all compared to dalteparin, the low molecular weight heparin. So the outcomes that we're looking for were primary efficacy outcomes, VTE recurrence, primary safety outcomes, and measure bleeding. So these are the malignancies, the cancer type distribution in the different studies. So almost all the important malignancies were included, including hematological malignancies. As you can see, particularly in the Hoxai study with edoxaban, 56 patients, okay? Totally more than 110 patients with hematological malignancies were included. So these are actually very important studies that actually included almost the very important malignancies in humans. So the results, as you can see, I'm sorry, it is not really very clear, but as you can see in the Hoxai study, dalteparin versus edoxaban, okay? The VTE recurrence was 11.3 for dalteparin versus 7.9 for edoxaban. The p-value was 0.09, borderline. And the select study that compared dalteparin, rivaroxaban, okay, there was no significant difference as such, but the measure bleed was actually probably more in the NOx in general in these studies. So the conclusion from these studies was that the DOX are associated with low recurrent VTE, okay, and the higher non-measure bleeding compared to dalteparin. This was the conclusion. So as you can see, the recurrent VTE was 9.1 with dalteparin taken together from the 4 studies, and 5.7 for DOX. So the p-value was significant in this situation. The measure bleeding was not really significant in that two groups, more or less the same, slightly increase in the DOX. And the clinically relevant non-measure bleeding was actually increased in patients who were talking DOX, okay? So this being the conclusion is, so when do we use then low molecular weight heparin in this group of patients? You remember I said DOX are given for selected patients, not all patients, okay? The exclusion, the patients that should not be given DOX, but low molecular weight heparin include in patients in whom drug-drug interaction is a concern, okay? Like, for example, patients taking some chemotherapeutic agents. In those who have undergone surgery involving upper gastrointestinal tract, because the absorption of all direct oral anticoagulants occurs in the stomach and the proximal small bowel, and patients who have gastrointestinal lesions, including peptic ulceration, bleeding polyps, and so on, should not be given DOX. Genitourinary lesions are also contraindications to the DOX. Are you following me, doctors? Hello?
Yes, we are following, doctor.
Okay, thank you. So the reason is, as you can see, interestingly, the NOx or DOX have local effect in the gastrointestinal tract. What they do is, if there is incomplete absorption, they have topical anticoagulant effect locally, so they result in bleeding, okay? They could also have direct caustic effect because of the content of tartaric acid. So if you have gastrointestinal lesions, the possibility of bleeding increases. And there is also reports have been forwarded that these drugs inhibit mucosal healing in this group of patients. So in conclusion, we should not consider the DOX or NOx, okay, in this group of patients with gastrointestinal problems or lesions. So over the years, as you can see, in the evolution of cancer-associated thrombosis, not only that, by the way, in general, also in general population, there is diminishing recurrent VTE rates, okay? As you can see, warfarin, in patients taking warfarin, the recurrence were range from 10 to 16%, with low molecular weight heparin 6 to 9%, and with the NOx or DOX, it was 4 to 8%. So who knows, there could be further improvement as we have new drugs. So really, this is a very important event in medicine. The direct oral anticoagulants have improved significantly the treatment and ease of the administration of medications in this group of patients. So some algorithm in the treatment of treatment selection for symptomatic and incidental VTE or PE in cancer patients in summary. So if you have a cancer patient with symptomatic or incidental DVT or PE, so the question you ask is, does the patient have drug-drug interaction with DOX, okay? Or is the patient at high risk of bleeding, such as the ones I mentioned, gastrointestinal malignancies? If it is no, then initiate anticoagulation treatment with DOX. So the drugs approved are apixaban, edoxaban, or rivaroxaban. If the answer is yes to the question is raised, then we have to give low molecular weight heparin to this group of patients. If extended anticoagulation treatment is required, evaluate the patient beyond 6 months of treatment, and then the oral anticoagulants or the DOX are the treatment of choice in patients who will require treatment beyond 6 months. Catheter-related thrombosis in cancer patients, if they have central lines, for example, in a cancer patient with catheter-related DVT, for example, in the catheter itself or elsewhere, is the central venous catheter infected, improperly positioned, or not functional? If yes, then remove the catheter and anticoagulate the patient for 3 months. If no, if the catheter is okay, 3 months anticoagulant treatment, don't remove the catheter, okay? And consider extended anticoagulation if the risk continues beyond 3 months. So these are actually the recommendations that are made from the guidelines that I mentioned already. So the ASCO guidelines for prolonged treatment beyond 6 months, okay, anticoagulation with low molecular weight heparin, DOX, or even vitamin K beyond the initial 6 months should be offered to select patients with active cancer, such as those with metastatic disease or those receiving chemotherapy. Anticoagulation beyond 6 months should frequently be evaluated. The patient should actually be followed, and intermittent evaluation to ensure favorable outcome is important. By the way, these are informal consensus. Evidence quality is low with the studies, with the guidelines. So this is only expert opinion and so on, because the randomized clinical trials of significance have not been reported yet. So these are the medications that we use. As you can see, the ones in brown or red are the ones that we have in our country. So there are 8 medications that should be considered in the treatment and prevention of thrombosis in this group of patients. So the contraindications to anticoagulation, as you can see, probably we have discussed this repeatedly, but absolute indications include major bleeding, life-threatening bleeding, platelet counters like below 50,000, okay? But you can still give anticoagulation until a platelet count of 20,000, okay? Or so if anticoagulation becomes important in this group of patients with thrombocytopenia, we can transfuse the patients with platelets, and we can also decrease the dose of the anticoagulant by 50%. Otherwise, you have to give standard anticoagulation for patients who have a platelet count of about 50,000. So relative contraindications are mentioned. You know, I should not go into details, but we always should see what the patient would have contraindications that could be absolute or relative contraindications, and accordingly administer medications. And if the patient bleeds, then what do we do? Like, for example, the patient bleeds on an emergent basis, or the patient requires surgery. How do we actually make sure that the patient would undergo surgery with reversal agents, okay, antidote, and so on and so forth? So for the oral anticoagulants, we have the annexanet now, which is not available. Annexanet for rivaroxaban and apixaban. We have a monoclonal antibody for idarucizumab for dabigatran, okay? But for patients who require acute correction of bleeding, then 4-factor prothrombin complex concentrators are very, very helpful in these patients. And if the patient has taken a medication earlier on, like within 2 hours, then we can consider oral charcoal and so on and so forth. For heparin, you know, protamine sulfate is the neutralizing agent of choice. That would also work for molecular weight heparin. The dose slightly increased, but we have to still consider protamine sulfate for this group of patients. So we have to read this. These are very important issues. You know, reversal agents we may not have, but I think judicious use of you know, fresh frozen plasma, platelets, and also correction of the bleeding of the patient with transfusions would be helpful in our situation. But we can, for example, in a patient taking warfarin, we can give vitamin K as well as fresh frozen plasma, and we can actually help the patients. We do not have significant problems in this regard, except you know, fewer times when you actually consider acute bleeding or surgery in this group of patients, and you have to achieve normal hemostasis. Then it may become difficult in our situation. Otherwise, please read on this. These are important, you know, for a clinician. I should not go into details. Now, at last, I would like to address the issue of, just bear with me 5 minutes, okay, prophylaxis. So the prevention of VT in patients with cancer can be primary, or preventing initial occurrence of cancer-associated thrombosis, or secondary, preventing recurrence, continuous treatment beyond 6 months in eligible patients. So the studies say that routine thrombophilaxis should not be offered to all patients with cancer. These are patients, outpatient, ambulatory patients, don't forget. Okay, these are ambulatory patients. So high-risk patients with cancer, okay, and the corona score, as you are going to see later, more than 2 may offer thromboprophylaxis with apixaban, rivaroxaban, or low molecular weight heparin. Patients with multiple myeloma receiving thalidomide, lenalidomide, pomalidomide, as I said earlier on, should be put on ASA, low molecular weight heparin, based on the risk factors that are identified in this group of patients. So this is a corona predictive model for chemotherapy-associated venous thromboembolism in ambulatory patients, okay? So, you know, the risk categories we have low, where the risks, the development of symptomatic VTE is between 0.3 to 1.5, intermediate, high, where you see symptomatic VTE in about 7 to 13% of patients. This was actually forwarded in the year 2008 by Corona et al. So as you can see, if you group the Corona score into two, and if you have a Corona score between 0 and 1, the red one, so the cumulative incidence of VT is less than, for example, 2, okay? So these are actually low-risk patients. In patients who have two or more than 2 risk factors, then the incidence of VTE increases exponentially to 13%. You remember the maximum in the Corona scale to 13% and beyond. So these are very important. Ambulatory patients, we have to classify our patients, okay, risk stratify them into low, intermediate, and high. Intermediate risk patients may be considered for anticoagulation based on particularly the malignancy they have. If they have, for example, brain tumor or pancreatic CA or gastric CA, then we have to anticoagulate, to give them anticoagulation. For patients with higher coronary risk score, then it is mandatory to give prophylaxis for ambulatory patients with malignancy. So the conclusion is a systematic review and meta-analysis of 6 studies that were reported in Medicine in 2020. The conclusions were that drugs show comparable efficacy to low molecular weight heparin, okay, in cancer patients without VTE, with a slightly higher measured bleeding occurrence rate in patients given the drugs. So the drugs are an alternate thromboprophylaxis strategy in cancer patients, as they have comparable or even better results compared to the traditional anticoagulants. Further studies are still required because these studies, the reports of these studies did not actually achieve significant, okay, difference between the low molecular weight and the drugs. So the recent studies, like the AVERT clinical trial, okay, apixaban to prevent thromboembolism, okay, the conclusion in the New England Journal of Medicine was apixaban therapy resulted in a significantly lower rate of VTE, 1.1 versus 13.8 than the placebo, okay? So these drugs, the NOx in these studies, apixaban have been found to actually avoid cancer-associated thrombosis in these ambulatory patients. But the rate of measured bleeding episodes was higher with apixaban than with, for example, placebo. Rivaroxaban for thrombophylaxis in high-risk ambulatory patients, as you can see, the Cassini study also showed that during the intervention period, rivaroxaban led to substantially lower incidence of such events with low incidence of even bleeding in this group of patients. So these are the drugs that we use in prophylaxis: unfractionated heparin, the doses indicated, dalteparin, enoxaparin, fondaparin or apixaban, and rivaroxaban. Now, the doses are as indicated. We have rivaroxaban, enoxaparin, and unfractionated heparin in our country, so we can use this properly. So in summary, Thrombosis is a common complication of cancer and is associated with significant morbidity and mortality in cancer patients. Okay. Although low molecular weight heparins have been recommended for the treatment of cancer-associated thrombosis for years, recent trials show that the direct oral anticoagulants can also be effectively used for the management of cancer-associated thrombosis. The direct oral anticoagulants also show comparable efficacy to low molecular weight heparin for prophylaxis of VTE in cancer patients with slightly increased clinically relevant non-measured bleeding. Okay, this is very important. Hospitalized patients who have active malignancy and acute medical illness, additional medical illness, or reduced mobility should be offered pharmacologic thromboprophylaxis in the absence of bleeding or other contraindications. Current guidelines do not recommend routine thromboprophylaxis for all ambulatory patients with cancer. They advise considering anticoagulation in selected patients with intermediate to high risk category based on the corona risk score. So this is what I have. Thank you for your attention. If you have questions, comments, please. Thank you. Hello?
Hello, Doctor. Okay, thank you for this. Okay, Dr. Tedros, you can proceed.
Okay, thank you, Dr. Amha, for the great talk. I have just one or two questions. One is, why is this cancer-associated thrombosis more common in certain types of malignancies? Is it because of release of this some tissue things that we are mentioning, like the in-brain tumor and the like? And so one is that, and is there so if we know that certain types of tumors are is associated with higher rate of thrombosis, so do we focus on such group of patients also for prevention? And the other is, you mentioned that I was surprised that you mentioned dexamethasone is associated with thrombosis, and now we are using dexamethasone for management of COVID, who are at high risk of COVID patients who are at high risk of thrombosis. So what's your comment? Shall we use other types of steroids, or how serious is really this risk of dexamethasone with causing thrombosis? Thank you.
COVID patient
Okay. Thank you, Dr. Tedros.
I think.
Hello? Hello, can you hear me?
Yes, Doctor.
Yes.
Okay, so thank you for these important questions, Dr. Tedros. Like, as you can see, some malignancies, particularly mucin-producing malignancies, they are actually complicated by increased incidence of cancer-associated thrombosis. Top on the list is pancreatic CA. It produces mucin. It also produces tissue factor and other soluble, products of the cancer that stimulate thrombosis formation intravascularly. The release of tissue factor combined with the mucin production results in immediate, production and needles in the intravascular, in the endothelial cells, and therefore they develop cancer-associated thrombosis subsequently. As you can see in the corona predictive rule, okay, so the patients, the patient with very high risk are the stomach and the pancreas. Okay, as I said, these are mucin-producing malignancies. These are the lung, lymphomas, gynecologic cancer, bladder, and testicular are also associated with increased cancer-associated thrombosis because of the production of tissue factor and other soluble okay, tumor products that stimulate the neutrophils as well as monocytes. If you remember when I talk about the pathogenesis of cancer-associated thrombosis, these are very important events. Particularly activation of neutrophils form the neutrophil extracellular traps that actually trap the platelets, resulting in platelet aggregation intravascularly, and in the nidus that has already been formed by the interaction between endothelial cells and the malignant cells. Okay, so this is a very important question, and actually always, particularly for patients who are ambulatory, we have to consider this issue and then categorize our patients into low, intermediate, and high, and therefore put them on prophylactic anticoagulation. In the patients who develop VTE or cancer-associated thrombosis, there is no problem. You have to anticoagulate them. I mean, as a rule, they have to be anticoagulated unless there are contraindications. But the most important is in the prophylactic anticoagulation. In this group of patients, we have to categorize them. The second question is, cancer-associated thrombosis associated with steroids and hormones. This has been reported in many patients, okay? And we have seen this in a few of our patients, for example. Dexamethasone should be given for a short period of time. That's why you don't go beyond 4 days maximum, with tapering 7 days. If you go beyond that, the incidence of cancer-associated thrombosis, or even, in patients without cancer, the incidence of venous thromboembolism increases. So it should be short, high dose, short course of dexamethasone treatment. With the other steroids as well as hormones such as tamoxifen, it is known that they are complicated by the development of thrombosis. So I should not go into details in this regard. I hope I have answered your question, Dr. Tedros.
Yes, thank you, Dr. Amha. Thank you.
Any other comment, question, please?
I think we have gone beyond.
Dr. Amsalu, probably.
Okay, sure, make it
Yeah,
short.
thank you, Dr. Amha, for your excellent talk. And then my question is in terms of duration of anticoagulation for somebody who developed thrombosis in the presence of cancer. So sometimes the cancer activity may be still there. So what is the limit for duration of anticoagulation, or is there any, what are the criteria to prolong duration of anticoagulation? Thank you.
Thank you, Dr. Amsalu. Again, very important question. In general, if the cancer has been treated and the patient has already developed venous cancer-associated thrombosis, their treatment range is from 3 to 6 months, on the average 6 months. Now, when do you consider, to continue treatment beyond 6 months? Now, if the patient has active malignancy ongoing, then you have to consider treatment, continue treatment, particularly metastatic disease. The other thing is, if the patient requires treatment, is he or she is still on treatment? That could be radiotherapy, chemotherapy, or other modalities of treatment. We have to continue treatment, anticoagulation. Once the treatment of cancer is stopped and the cancer is controlled, then we may consider discontinuation of the anticoagulation. Now, here comes actually an ethical question, where you have a patient with advanced malignancy, where the outcome is poor. I mean, the expected life expectancy of the patient is less than 6 months. Then in that case, I don't think we should, there are guidelines, by the way, to that regard, that actually advise to maintain the comfort of the patient, okay, decrease costs, and so on and so forth. So it would not be really reasonable to continue treatment in this group of patients where their life expectancy is very short. In that regard, you have to stop treatment. I hope I have answered your question, Dr. Amsalu.
Yeah. Thank you.
I think we have gone past 70 minutes from the usual allotted time. It would have been good if you accepted more questions, but due to time constraints, let's wind it up here. Dr. Amha, thank you so much for the
Thank you, everybody. Have a great day. Thank you.
Same to you. Bye.
Thank you.